Hi, my name is Bianca Colson. I am a member of our acute care speech pathology team at Sinai Hospital. I have worked in various settings throughout my career, and one repeated concern that I have frequently encountered has driven me towards obtaining a specialty in palliative dysphagia. Years of research and collaboration with an interdisciplinary team has generated this hospital-wide initiative that I am bringing to you today. Before talking about this initiative and your specific role, I first want to introduce to you a patient of ours so that we're going into this discussion all on the same page. This patient is an 84-year-old male who presented to Sinai Hospital in September of 2021 with concerns of cognitive decline, worsening confusion, not sleeping at night, and poor PO intake. The patient had a history of hypertension, remote seizures, and Parkinson's disease. His head CT on admission demonstrated encephalomalacia, and his hospital course was complicated by urinary attention and an acute kidney injury. Nursing had raised some concerns for dysphagia, which resulted in an SLP consult. Our team did a modified barium swallow study on September 22nd, which identified a moderate to severe pharyngeal dysphagia with aspiration of all liquids. As part of our standard SLP evaluation, this patient's spouse was interviewed for his most recent prior level of function. His spouse had identified that just a few days prior to admission, the patient was able to join his family for a big dinner. And it was a very meaningful experience for everyone in his family, and he didn't seem to have any trouble with swallowing. Prior to this meal, his spouse did endorse that he had had some poor sleep habits. He was inconsistently sleeping through meals, and he had had a significant weight loss. So in summary, he's had a cognitive decline. He does have a history of Parkinson's disease. He was identified to have malnutrition on admission. We now have an identified dysphagia with aspiration. We also know that he was living at home with his family who was caring for him. He was mobile, and he was fairly dependent for his ADLs. So when we come to the question of how to manage his nutrition, we need to ask ourselves, what is in the best interest of the patient? What places him at the highest risk and what places him at the best benefit? So he is at a nutrition risk. He is confused. He is agitated. He's sleeping a lot, and he's also aspirating. Our role as a speech therapist is to identify the risks and benefits of eating, as well as the risks and benefits of enteral feeding or placement of a feeding tube. So when we look at the potential of this patient resuming an oral diet, you might think he's aspirating, which means he's going to develop pneumonia, right? As a speech pathologist, our role is to review the risks of aspiration pneumonia as dependent on the entire patient. One way that we look at this is through the pneumonia risk predictors. We know that aspiration alone does not lead to pneumonia. You'll look at this chart and you'll see that three major factors come into play. One is the oral health status. So how is this patient's oral hygiene? The second is laryngeal valve integrity, which means is the patient aspirating or not? And the third is the immune system status. So how many medical comorbidities are coming into play? You'll see at the chart that just because a patient may have aspiration present on their exam does not mean that they have a predicted outcome of developing a pneumonia. You'll also see that in the column 8, with poor oral hygiene status, the presence of aspiration, and a reduced immune system, we do have a patient who is at high risk of developing pneumonia. So now we can consider the risks and benefits of a feeding tube placement for this patient. Let's go to the research. The risks associated with PEG tube placements in a patient with advanced cognitive impairment are as follows. First of all, 76% of patients requiring NG tube or PEG tube placement with cognitive impairment will require restraints at some point. Some research has also shown that hospitalized nursing home residents with advanced cognitive impairment who receive a PEG tube are 2.27 times more likely to develop a pressure ulcer than those without a PEG tube. We also know that there is no improvement in functional nor nutritional outcomes after a PEG tube placement in patients with dementia. Neither short nor long-term alternative nutrition and hydration, or NG or PEG tube, decreases the mortality rate in patients with dementia. We still have a 54% mortality rate within 30 days and a 90% mortality rate within a year. Finally, in patients with dysphagia and dementia, survival is equally short with and without a feeding tube, which is about 6 months. Here are some facts from the research that we know about the general risk of aspiration and tube feeding relationship with elderly adults. Aspiration pneumonia risk is not reduced with placement of an NG or a PEG tube in elderly patients. So this is anyone over the age of 75. Aspiration occurs frequently after the placement of a PEG tube in an older adult. 50% of these older adults with feeding tube placements are identified to have aspiration. We also know that the misdirection of contaminated oral secretions is the most common contributor to aspiration pneumonia, and it is not reduced nor eliminated by the placement of a feeding tube of any kind. And finally, reflux of gastric contents is increased due to a reduction in the pressure of the lower esophageal sphincter when we place an NG tube. So in the case of our current patient, we need to ask, is placement of a feeding tube a benefit to this patient? A quick note on bioethics. We are responsible for providing treatment that is merciful, kind, and caring, and we only do what is medically and ethically helpful. If the placement of a feeding tube is deemed an unbeneficial treatment, wherein the burden of suffering and intrusiveness of the treatment itself will outweigh any potential benefit and will ultimately contribute to an undignified death, is this something that we want to offer? In counseling this family for decisions surrounding this patient's nutrition, we have two options. One is for this gentleman to continue eating. In this scenario, he does remain at risk to aspirate, but we are also preserving his quality of life as well as his family's quality of life in spending time with him for however much longer he is to live. The other option is to offer a feeding tube. Will this patient benefit from placement of a feeding tube? We know now that we will not eliminate his risk of aspiration with placement of a feeding tube. Research also tells us that placement of a feeding tube in this specific patient population does not prolong life nor improve the quality of life. This patient case scenario is part of the reason why I am presenting to you the initiative of a permissive diet. A permissive diet is an oral diet which is selected when a patient or their decision maker or family member has made an informed decision to resume an oral diet when the patient is either not a good candidate for enteral feeding, will not benefit from PEG tube insertion, and or have selected to resume eating by mouth despite the associated risks that may include aspiration, pneumonia, or nutritional insufficiencies. The permissive dysphagia diet is presented as a power plan. The modified dysphagia diet textures are still available within the permissive diet. Also included will be universal aspiration precautions, which hopefully everyone is familiar with, Q6 oral care, and something called careful hand feeding in order to provide this oral diet as safely as possible. Careful hand feeding is to be used in conjunction with the permissive dysphagia diet. If the patient is unable to feed themselves, careful hand feeding administered by nursing staff may be recommended by your speech pathologist as a means to administer food and drink in the safest way possible. Universal aspiration precautions are to be used in addition to some careful considerations with these patients. These patients must be seated fully upright at a 90-degree hip angle as tolerated. You will be offering food and drink only when the patient is alert and aware of the eating task. This is not dissimilar to most of our dysphagia population. Prior to presenting food or drink, you will check the oral cavity or offer suctioning and hygiene as needed. Placing the food in front of the patient so they can see and smell the food will improve their engagement in the eating task. Also telling your patient what they're eating and allowing them to make choices as they are able. Mixing all the foods together and getting as much as possible in at a time is not beneficial to these patients. To improve patient awareness of task, using hand-over-hand feeding is a big benefit. This is done by placing a cup or a utensil in the patient's hand, typically their dominant hand, and placing your hand over top of their hand in order to guide the food and drink to their mouth. you're also going to feed the patient at a slow rate. And just as any clinician, you are able to make the judgment call to stop the feeding if your patient shows any adverse reactions to the food or drink that they are being provided. Any adverse reactions may include an increased work of breathing, or if they're being monitored, you could look for tachypnea, desaturations, or if the patient has persistent coughing, throat clearing, or that wet, gurgly quality to their upper airway. We can expect that these patients may have some intermittent coughing or throat clears, as they have likely been identified as patients who have a presence of aspiration when eating and drinking. At any point, if the patient demonstrates discomfort with what you are feeding the patient, then you discontinue that meal and try again later. The escalation procedure is similar to any patient when we have concerns with aspiration. You'll notify the provider, and you can also reach out to speech therapy on Vocera by calling speech therapy. A couple of tips I want to highlight is to prompt the patient to swallow a bite of food or a sip of liquid before you put more in their mouth. Another highlight is that we want to be inviting family members to visit during meal times and educate them on these feeding strategies. Most of the time, the family members are the ones who are making the decision to resume careful hand feeding. Therefore, we really want to involve them in the education and the presentation of food and drink so that they can be most comfortable in how they want to provide this food and drink to their family member. And another big highlight is to perform oral care after every meal. We want to check for any oral residue or pocketing, since we now know how important oral hygiene is to the prevention of aspiration pneumonia. So what happened to our patient that I presented in the beginning? The patient in the case study was discharged to Levendale on a permissive oral diet of pureed solids and water only between meals after oral care. He continued eating while at Levendale with the risks of aspiration. He had speech therapy for about a month, and then he had a repeat modified barium swallow study in October, which did not show any improvement in his swallow function. During his stay at Levendale, he continued eating meals in a group setting and enjoyed that quality time with his family and with caregivers. The patient became more alert during his rehab stay and more participatory throughout the day. He did not have any reported respiratory complications while he was on the SLP caseload. He was discontinued from the speech therapy caseload in October, and he passed away in January, 5 months after his initial dysphagia was identified. The Permissive Dysphagia diet is scheduled to go live on May 3rd. The diet order will have blue text reference that will be linked to the careful hand feeding guidelines so that you have them quickly and electronically whenever you need to reference them. Also keep an eye out for some educational resources for nursing as well as patients and family members. That is to come in the next few weeks. As always, please reach out to your speech therapy team with any questions, concerns, education, or further coaching on how to best provide this permissive dysphagia diet. I'm Bianca Coulson. I look forward to working with all of you, and thank you for your time.